Fractures and joint injuries. General incidence and significance. Increasing participation in high-speed travel by land, sea, and air, complex industry, and competitive and recreational sports may result in high number of trauma. It is the number one killer of young people in North America with annual costs of more than $160 million. Trauma patients occupy 10% of all hospital beds, with 2/3 involve musculoskeletal system. Isolated musculoskeletal injury can result in low mortality but higher morbidity, while multiple injuries result in high mortality and high morbidity. Fractures and associated injuries. Fracture is a structural break in continuity and always produces some degree of soft tissue injury as well. Radiographs seldom provide evidence of the extent of associated soft tissue injuries, such as in brain, spinal cord, and thoracic or abdominal viscera. And the soft tissue injuries sometimes have much greater clinical significance than the fracture itself. Physical factors in the production of fractures. The physical nature of bone has a degree of elasticity or flexibility. Cortical bone is able to withstand compression and shearing forces, but not tension forces. Tension failure can happen by bending, twisting, or straight pull. Bending may cause transverse or oblique fracture. In young children, it can result in green stick fracture. Twisting is resulting in spiral fracture, while straight pulling can result in avulsion fracture. Cancellous bones is more susceptible to crushing force. Compression may result in compression fracture impacted to opposite side. Buccal fracture or thorax fracture in the metaphysis can happen to children. The causative force may result in direct or indirect injury. Figure 15.1. A. Transverse fracture of the femoral shaft. B. Oblique fracture of the femoral shaft. Figure 15.2. Green stick fracture of the radius and ulna in a child. Figure 15.3. Spiral fracture of the femoral shaft. Figure 15.4. Avulsion fractures. A. Avulsion fracture of the patella, which is a sesamoid bone in the quadriceps tendon. The fragments remain restricted because of quadriceps muscle pull. B. Avulsion fracture of the medial malleolus that has been pulled off by the intact medial collateral ligament of the ankle at the time of a severe abduction external rotation injury of the right ankle. Note also the slightly angulated fracture of the fibula and the lateral position of the talus. The attachment is so secure that the tendon does not pull out of bone. Tension failure occurs either through the bone or through the ligament first. Figure 15.5. Compression fractures of the cancellous bone. A. Compression fracture of the surgical neck of the humerus in an elderly adult, not the impaction of the fracture on the medial side. B. Compression fracture of a vertebral body in the mid-thoracic region of an adult. The vertebral body has lost height anteriorly and has become wedge-shaped as a result of being compressed. Figure 15.6. Buccal fracture in the metaphysis of the radius of a 7-year-old boy. The thin cortex has buckled but has not completely broken. In this child, the buccal fracture is more obvious in the lateral projection than in the anteroposterior projection. Figure 15.7. Fracture dislocation. A. Fracture dislocation of the elbow in an adult. Note the fracture of the shaft in the ulna and the neck of the radius as well as the dislocation of the elbow joint. B. Fracture dislocation of the right shoulder in an adult. Note the fracture of the greater tuberosity of the humerus and the dislocation of the humeral head in relation to the glenoid cavity. Descriptive terms pertaining to fracture: 1. Site, diaphyseal, metaphyseal, epiphyseal, interarticular, and fracture dislocation. 2. Extent, complete or incomplete, crack or hairline or green stick. 3. Configuration, transfer, oblique, spiral, comminuted. 4. The relationship of the fragments to each other: A. Translated, B. Angulated, C. Rotated, D. Distracted, E. Overriding, F. Impacted. 5. The relationship of the fracture to the external environment: A. Closed, B. Open. And 6. The presence or absence of complication: uncomplicated or complicated, local or systemic, and original injury or iatrogenic. Figure 15.8. Hairline or crack fracture in the distal third of the tibia in a child. Because there is no displacement, the fracture line is apparent in only one projection. Figure 15.9. Comminuted fracture. A. Comminuted fracture of the shaft of the femur in a child. There are 2 fracture lines and hence 3 fragments. Because of its shape, the third fragment in this type of comminuted fracture is referred to as Bartholdi fragment. B. Severely comminuted fracture of the distal end of the femur in a young adult who had fallen from a 5th-story window. The tremendous force of the impact has shattered the bone into many fragments. Figure 15.10. Open fractures. A. Open fracture of the distal metaphysis of the ulna. A sharp fracture fragment has penetrated the skin from within. B. Open fracture of the foot. The blades of a hay mower have penetrated the skin from without and have produced multiple fractures. Associated injury to the periosteum. Periosteum is an osteogenic sleeve surrounding bone and is an important factor in healing. Thicker, stronger, and more osteogenic in children, mostly thicker in area covered by muscle than subcutaneous or synovial joint. Intact periosteal hinge in children may result in green stick fracture and can be used in advantage of reduction. Diagnosis of fractures and associated injuries. Diagnosis of fracture may be obvious or not, especially if undisplaced or impacted and stable. It is important not to overlook associated soft tissue injury, visceral injury, coexistent dislocation, or even second fracture. Patient's history: fall, twisting, direct blow, road accident. Exact mechanism of injury is lacking. Localized pain aggravated by movement, decreased function, may have crepitus. Physical examination consists of inspection for swelling, deformity, abnormal movement, and ecchymosis, feeling, sharply localized tenderness at the site of fracture, aggravation of pain, and muscle spasm when moved and moved. There may be more than one injury, so careful assessment of associated brain, spinal cord, peripheral nerves, major facial, skin, thoracic, and abdominal visceral injury is important. Figure 15.12. The danger of overlooking a second fracture. A. If the physical examination revealed an obvious fracture of the elbow and the wrist was not examined also, a radiograph like this might be obtained, which demonstrated a displaced supracondylar fracture of the humerus. B. If the physical examination revealed an obvious fracture of the wrist and the elbow was not examined also, a radiograph similar to this might be requested, which demonstrates a displaced fracture of the radius and an undisplaced fracture of the ulna. C. Careful physical examination will have led a practitioner to obtain this radiograph, which provides clear evidence of all 3 fractures. Figure 15.13. Examples of clinical fracture deformities. A. Angulation deformity in the right forearm of a child with a green stick fracture of the radius and ulna. B. Angulation, external rotation, and shortening deformities in the right thigh of a child with a completely displaced and overriding fracture of the femoral shaft. C. External rotation deformity of the entire right lower limb of an elderly lady with a displaced fracture of the femoral neck. Figure 15.14. Ecchymosis in the skin of the axilla and upper arm of an adult 3 days after he had sustained a fracture dislocation of the right shoulder. The hematoma in the deep tissues has gradually spread into the subcutaneous tissue. Diagnosis of fractures and associated injuries. Diagnostic imaging. It is required to determine the exact nature and extent of the fracture. The patient should be provided with some type of radiolucent spleen for immobilization. Entire length of the injured bone and the joint at each end, 2 joints. AP and lateral, 2 projection. Sometimes we even need oblique projection. CT or MRI may be needed for fracture of spine and pelvis. For undisplaced fracture may become apparent after 1 to 2 weeks as a result of the healing process. Figure 15.15. The importance of including the entire length of the fracture bone and the joints at each end in the radiographic examination. A. This inadequate radiographic examination reveals only an angulated fracture of the ulna. B. This radiograph reveals, in addition to the fracture of the ulna, a complete anterior dislocation of the proximal end of the radius in relation to the capitellum. This combination is known as a Montague fracture dislocation. Figure 15.16. The importance of at least 2 radiographic projections at right angles to each other, anterior-posterior and lateral. A. The anterior-posterior projection reveals little evidence of disturbance of the tibia or fibula. B. The oblique fracture of the fibula is obvious in the lateral projection. C. The anterior-posterior projection in the severely injured boy reveals relatively little evidence of disturbance of the spine. The radiolution area across the top half of this radiograph represents gas in the dilated stomach, acute gastric dilatation. D. The lateral projection reveals a severe fracture dislocation of the lumbar spine. Figure 15.17. The importance of oblique radiographic projection. A. In the anterior-posterior projection, there is only slight evidence of a fracture of the medial malleolus. B. The lateral projection reveals no evidence of a fracture. C. This oblique projection clearly demonstrates a displaced intra-articular fracture of the medial malleolus and disruption of the joint surface, as well as of the epiphyseal plate, the physis. Figure 15.18. Computed tomography scan of the first lumbar vertebra of a young adult who had sustained a spinal injury from an automobile accident. A cross-sectional slice of the spine at this level as viewed from below. Note the fractures of the vertebral body, the lamina in the midline, and the right transverse process on the left of the computed tomograph. The fractures of the vertebral body and lamina were not readily detectable in the conventional anterior-posterior and lateral radiograph. Figure 15.19. Late evidence of a fracture. A. Ankle of a 10-year-old boy on the day of injury. He was thought to have a sprained ankle and there is no radiographic evidence of a fracture. B. The same boy's ankle 2 weeks later reveals superioceous newborn formation along the lateral aspect of the tibia, and this provides late evidence that the original injury was a fracture separation of the distal tibial epiphysis with spontaneous reduction rather than a mere sprain. Normal healing of fractures. Fractured bone can heal without a scar. Mechanical fracture, immobilization, and biological fracture is important. Cooperate with the law of nature. TGF-beta superfamily, IGF, PDGF, BMP, and interleukin is important in enhancing fracture repair, different in the dense cortical bone and spongy cancellous bone. Healing of a fracture in cortical bone. Initial effects of the fracture. At the moment of fracture, tiny blood vessels canaliculi in the Haversian are torn. After a brief period of internal bleeding, normal clotting is formed. These tiny blood vessels extend from a short distance from the fractured site. Osteocytes, for a distant few millimeters, lose their blood supply and die, and always make ring of a vascular dead bone at each fracture surface, eventually replaced by living bone. In a relatively undisplaced fracture, internal bleeding comes from torn nutrient artery or its branches of periosteal sleeve, while localized fracture hematome around the bone ends. In severely displaced fracture, larger arteries in the surrounding muscle and fat are also torn, resulting in massive hematoma. Healing of a fracture in cortical bone. Early stages of healing from soft tissue. The fracture hematome is a medium of early stages of healing through a reaction of the soft tissue around the fracture. Repair cell, osteogenic cells from periosteum form external callus, while from endosteum form internal callus. Early stages of fracture healing comprise of extremely rapid growth of osteogenic tissue, resulting in formation of fracture callus at the end of first week. At this stage, it is still radiolucent, initially soft callus, primary woven bone. If osteogenic cells differentiate to osteoblasts, if less blood supply and movement, osteogenic cells will differentiate to chondroblasts. Healing of a fracture in cortical bone. Stage of clinical union. Temporary external and internal callus is a mixture of primary woven bone and cartilage surround the fractured site to form biological glue, gradually hardens by endochondral ossification. When fracture callus becomes sufficiently firm and no longer move, it is a clinical union. However, it is not restored to original strength. Radiographs still appear fracture line. Stage of consolidation, radiographic union. Eventually, temporary callus will form into mature lamellar bone. Excess callus is resorbed. After many months, when callus have been replaced by mature lamellar bone, it is consolidated and it is radiographic union, sound bony union. Excessive callus is resorbed. Wolff's law. Healing of a fracture in cortical bone with rigid internal fixation. When fracture has been acutely reduced and fragments have compressed and held by rigid internal fixation, stress protected and hardly knows it has been fractured. Under these conditions, no stimulus for external from periosteum or internal callus from endosteum, the fracture healing occurs directly between cortexes, primary bone healing. However, bone underlying metallic device, stress protected, tends to develop disuse osteoporosis and stress relief osteoporosis. Figure 15.21. The stages of fracture healing in cortical bone. A. The day of injury. A transverse fracture is seen in the midshaft of the left femur of this 8-year-old girl. The fracture has been aligned by means of continuous traction and a Thomas spleen, part of which is seen in this radiograph. B. 2 weeks after injury, callus is evident on the lateral aspect of the fracture and has glued the fragment together. At this stage, the fracture was clinically sticky and consequently, continuous traction was replaced by a hip spica cast. C. 8 weeks after injuries, callus is abundant and the fracture line is barely apparent. Clinical examination at this stage revealed no movement at the fracture site and no pain on attempting to move it. Thus, the fracture has healed to the stage of clinical union. The cast was removed and full weight bearing was allowed. D. 6 months after injury, the excess callus has been resolved, the medullary cavity has been re-established, and fracture healing has reached the stage of radiographic consolidation. E. 18 months after injury, the fractured femur has returned almost to its normal shape through the process of remodeling, which is an example of Wolff's law. Healing of a fracture in cancellous bone, metaphyseal bone or cuboidal bone, more trabeculae, thin cortex, cross-sectional area mainly from trabeculae, rich blood supply, and large area of bony contact in undisplaced and well-reduced fracture more quickly heal than in cortical bone. The healing mainly from internal or endothelial callus. Endothelial callus form woven bone and then laminar bone and then trabecular pattern re-established. As you may recall, cancellous bone is susceptible to compression or crush type injury. Figure 15.22. The stages of fracture healing in cancellous bone. A. The day of injury, a transverse angulated overriding fracture of the metaphyseal region of the distal end of the radius and an angulated fracture of the same region of the ulna are seen in this radiograph of the wrist of a 10-year-old boy. B. The same day, the post-reduction radiograph taken through the plaster cast reveals satisfactory reduction on both fracture. C. 6 weeks after injury, endothelial callus and periosteal callus are adequate, although the fracture lines are still apparent. At this stage, there were no movement at the fracture site and no pain on attempt to move it. This is the stage of clinical union, and immobilization was discontinued. D. 6 months after injury, radiographic examination reveals obliteration of the fracture line. The fracture healing has reached the stage of radiographic consolidation. Internal and external remodeling of the bone at the fracture sites is also apparent. Note the amount of longitudinal bone growth that has taken place from the epiphyseal plate since the injury, the distance between the epiphyseal plate and the fine radio-opaque line, Harris line, just proximal to it. Healing of a fracture in articular cartilage. Hyaline cartilage is extremely limited in its ability to regenerate, heals by fibrous scar, or fail at all. Either will cause degenerative changes. Any step in the fractured joint surface leads inevitably to degenerative arthritis. Immobilization versus intermittent active motion versus continuous passive motion. Continuous passive motion leads to 80% of articular healing in groups of rabbit. CPM is thought to enhance articular healing and prevent degenerative arthritis. Figure 15.23. Post-traumatic degenerative arthritis in the ankle of a 57-year-old man whose original intra-articular fracture had occurred 25 years previously. Note the incongruity of the joint surface, subchondral sclerosis, and osteophyte formation. Figure 15.24. Photomicrograph of the experimental fracture site in articular cartilage, safranin O stain. A. Normal intact articular cartilage of the femoral condyle of a rabbit. B. After 4 weeks of cast immobilization, the fracture in the cartilage has healed by fibrous scar tissue. C. After 4 weeks of cage activity, the fracture has failed to heal. D. After 4 weeks of CPM, the fracture in the cartilage has healed well. Healing of a fracture involving the epiphyseal plate. This special type of fracture merits special attention due to risk of local growth disturbance, more in Chapter 16. Time required for uncomplicated fracture healing extremely vary, depends on age, site and configuration, initial displacement, and blood supply. Age of the patient: young, more quick than old, closely related to osteogenic activity of periosteum and endosteum, less active with each year of childhood, and remain constant in adult to old age. For example, in child femur fracture, birth 3 weeks, 8 years 8 weeks, 12 years 12 weeks, 20 years 20 weeks. Site and configuration of the fracture: more surrounded by muscle, more rapid healing. Cancellous, more rapid than cortical. Long oblique, more quick than short transverse. Initial displacement of the fracture: undisplaced, more intact periosteum, more quick healing, and vice versa. Blood supply to the fragments: good blood supply leads to good healing. No blood supply lead to no healing until revascularized. Assessment of fracture healing in patients: assessed by both clinical and radiographic examination. Clinical: test by bending, twisting, and compression force. If no movement, clinically united. Clinical union: clinical union is evidence of bony callus but the fracture line still apparent. Radiographic consolidation: evidence of bony callus and obliteration of fracture line. Re-establishment of medullary cavity, remodeling phase. Abnormal healing of fracture: malunion, heal in time but in an unsatisfactory position with residual bone deformity. Delayed union, heal eventually but takes considerably longer time than normally expected. Non-union, fail completely to heal by bone, either by fibrous union or false joint pseudoarthrosis. Complication of fractures: only consists of minority. Majority of fracture heal without complication. A fracture may be complicated by an associated injury or become complicated subsequently, early or late, may local or remote, may be caused by original injury or iatrogenic. Classification of the complication of the original injury: initial, immediate complication. Local complication: skin injuries from without, abrasion, laceration, puncture, penetrating, loss of skin. From within, penetration from fracture fragment. Vascular injuries: major artery, major vein, local hemorrhage. Neurological injuries: brain, spinal cord, peripheral nerve. Muscular injuries: division of muscle. Visceral injuries: thoracic, intra-abdominal. Remote complication: multiple injuries or polytrauma, hemorrhagic shock. Classification of the complication of the original injury: 2. Early complication. Local: sequel of immediate complication, skin necrosis, gangrene, compartment syndrome, gas gangrene, venous thrombosis, visceral complication. Joint complication: septic arthritis, bony complication, osteomyelitis, AVN. Remote: fat embolism, pulmonary embolism, pneumonia, tetanus, delirium tremens. Classification of the complication of the original injury: 3. Late complication. Local: joint, persistent joint stiffness, post-traumatic OA. Bony: abnormal fracture healing, growth disturbance, chronic osteomyelitis, post-traumatic osteoporosis, Sudex post-traumatic painful osteoporosis through fracture. Muscular: post-traumatic myositis ossificans, late rupture of tendon. Neurological: tardy nerve palsy. Remote: renal calculi, accident neurosis. General principles of fracture treatment. General principles of fracture treatment. 1. First, do no harm. 2. Base treatment on an accurate diagnosis. A. When good external callus is expected, perfect reduction and rigid fixation are not essential. B. Base treatment on an accurate diagnosis. A. When good external callus is expected, perfect reduction and rigid fixation are not essential. B. When internal callus alone, perfect reduction and rigid fixation are essential. 3. Select treatment with specific aims. A. To relieve pain. B. To obtain and maintain satisfactory position of the fractured fragments. C. To allow and encourage bone union. D. To restore optimum function. 4. Cooperate with the laws of nature. 5. Make treatment realistic and practical. 6. Select treatment for your patient as an individual. Emergency Life Support System ATLS. A. Airway and C-spine protection. B. Breathing. C. Circulation. D. Disability, GCS, neurological. E. Environment. Preliminary care for patient with fractures. 1. Immediate care outside a hospital, resuscitation and first aid. 2. Care during transportation to hospital. 3. Emergency care in a hospital. Immediate care outside a hospital. As a healthcare professional, create order out of disorder, rapid assessment of the situation, initiate immediate care of the injured. ABC priorities: airway obstruction and C-spine control, watch for tongue and aspiration, initiate prone position and jaw thrust. Breathing, look for respiratory arrest only if the patient is not breathing. Circulation, cardiac arrest or severe bleeding, CPR or firm manual pressure to open wound. Shock, controlling hemorrhage and minimizing pain, no food nor fluid by mouth. Fractures and dislocation, if obvious, spleen and traction, beware of spinal cord injury. Figure 1526. Temporary limb splints at the scene of an accident. A. Upper limb splint. A short board has been bandaged to this man's fractured forearm before the sling is applied. For an injury above the elbow, a second sling or bandage can be used to bind the upper limb to the trunk. B. Lower limb splint. A long board has been bandaged to this man's injured lower limb, and then the two lower limbs has been bound together. He was also thought to have a spinal injury, and so is being gently rolled onto a long spinal board. C. Temporary Thomas splint that has been applied by an ambulance attendant for a man with open fracture of the femur. The pressure dressing over the open wound and the splint were applied before the accident victim was transported to hospital. D. The jaws of life being used by a firefighter to spread open a jammed car door to extricate a trapped occupant. Figure 15.26. Moving an accident victim who has a suspected spinal injury. A. A short spinal board is being strapped to the victim's back even before he is extracted from the wrecked automobile. B. The victim is then extracted as an immobilized unit. Transportation. The patient deserves gentle care, ideally using ambulance or something similar. Try not to squeeze him or her into a small car seat. Especially who may have sustained a spinal cord injury, use stretcher or suitable improvised alternative, cervical collar, short spinal board. Good care is more important than careless speed. Helicopters and medevac can be used in developed countries. Figure 15.28. A modern, well-equipped ambulance. The displayed equipment includes stretchers, spinal boards, air splints, oxygen tanks, positive pressure face masks, suction apparatus, gloves, and simple surgical instruments. B. Paramedics, emergency medical technicians attending an injured patient. C. Helicopter air ambulance leaving the scene of a serious traffic accident. And D. Arriving at a major trauma center. Emergency care in a hospital. All essential information must be gathered from the patient if possible. Allergies, medication, past history, last meal, events. Again, A, B, C. Airway obstruction, tracheal intubation and tracheostomy. Breathing, respiratory arrest, assisted respiration. Circulation, cardiac arrest or severe bleeding, defibrillator, clamp one or more vessels, and sterile dressing. Shock, prevention and recognition, typing and cross-matching, IV infusion by 2 large cannulas, CVP. If neurologic shock, consider opioid for analgesic. The detailed complex treatment in shock is constantly changing. Figure 15.29. An emergency or accident room equipped to treat patients who have sustained critical injuries. The equipment shown includes the following: anesthetic instruments to provide an airway, pharyngeal airways, laryngoscopes, endotracheal tubes, sealing source of oxygen, nitrous oxide, suction and diagnostic imaging, anesthetic machine, electrocardiograph with oscilloscope, defibrillator, firm surface under the patient's thorax in the event that close cardiac massage is required, auxiliary suction machine, blood pump for rapid transfusion, drugs for cardiac arrest ready for immediate injection, and cut-down tray for cannulation of veins. Responsibility for the care of the critically injured. Always need one captain, surgeon. Should seek immediately the help of colleagues in other specialties as necessary. Coordinate the efforts of all. Fracture and dislocation. After the first 3 priorities, rapid systematic physical examination is conducted. Vascular impairment, nerve injury, record before treating the fracture. After obvious fracture, seek other possible injury. Spleen before taken to radiograph. Figure 15.30. Temporary splint for fractured limbs prior to radiographic examination. A. Arm splint for a forearm fracture, a simple covered board and a bandages. B. Pillow splint for a fractured leg or ankle. There is less risk of circulatory disturbance and skin maceration with this type of splint than with an air splint. C. Thomas splint for a fractured femur. Figure 15.31. This child had an unstable fracture of the distal end of his radius and ulna. Radiographs requested, anterior-posterior and lateral projections. The child forearm should have been splinted before radiographic examination. A. A lateral projection of both proximal and distal fracture fragments. B. A lateral projection of the proximal fragments and an anterior-posterior projection of both distal fragments. Obviously, between 2 radiographic projections, the child's forearm has been rotated through the unstable fracture site by the technician. The child would have experienced much pain at this time and might even have sustained further injury to the related soft tissues. Thank you.